Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about osteoporosis. Osteoporosis is a very, very serious and common medical problem. Worldwide, there are 200 million people who suffer from osteoporosis. In this country, 44 million people have osteoporosis, and 55% of folks that are 50 years or older suffer from osteoporosis slash osteopenia first and then osteoporosis. Very common problem. Different ethnic groups are affected more than others. Whites and Asians are affected more with osteoporosis than Negroes. Negroes have denser bone by nature. As a result of that, they have a benefit that way. However, wherever there's a benefit, sometimes there is a deficiency as well. There's a negative, and that is, of course, the darker one's skin is, the more likely one is to have low vitamin D. And low vitamin D is a very common cause of osteoporosis. 95% of people of dark skin, regardless of what they think of themselves, have low vitamin D. And to make matters worse, 75% of people that are Negroes, like myself, have a problem with dairy product, a condition called lactose intolerance. And of course, the more you suffer from that, you don't drink milk, you can't eat butter, you can't eat this, you can't do that, then of course that increases the incidence of low vitamin D, which and so can cause osteoporosis. This stuff is very, very, very super complicated. And when I left off last week, I mentioned a whole lot of things about the parathyroid gland, and primary, secondary, all sorts of stuff. So in this segment, I'm going to start talking about the symptoms of osteoporosis, and then I'm going to begin to evaluate for you how we go about diagnosing osteoporosis. Now, of course, the symptoms are mainly bony in nature, mostly, not always, bony. And we're talking about fractures, and in particular, that can cause very disabling situation. Now, you got to understand that there are many other diseases, as I mentioned last week, that can be first presented at osteoporosis. So when one sees a patient who presents with osteoporosis, that patient must be completely, totally evaluated for other conditions that may be the reason for the osteoporosis, as opposed to just osteoporosis, the disease. Okay, so that being said, then therefore one then will go about, the symptoms, of course, bone pains and fractures. Some of the fractures are very disabling, and so on and so forth. So now we're going to go about this stuff. It is so complicated and so fascinating. I'm not going to sit here and bore you with all the detail. Suffice it to say, I'll mention a few things. You cannot have end-stage renal disease on dialysis without having secondary hyperparathyroidism. And then once you have hyperparathyroidism, by definition, you're going to wind up having osteoporosis. So I want you to understand the millions of people throughout the world that are on dialysis. But the dialysis doctors know that. So these people are placed automatically on vitamin D replacement. They take it every day. Okay, that's just the way it is. Once the kidney works in conjunction with the parathyroid gland in very significant ways. You can't make this up, because someone have primary hyperparathyroidism, whereby the parathyroid gland, there may be what we call an adenoma, which is an increase in the size of this gland, because it's very rare that one have cancer of the parathyroid gland. Super, super rare. Not impossible, but very rare. Most of the time we're talking about parathyroid adenoma. Well, the patient may very well present with a kidney stone. That's right. You can't have parathyroid disease, primary or secondary, without being exposed to the development of the possibility of developing kidney stone. Why? Because the higher the parathyroid hormone, the more it's going to bleach the calcium from the bone. And once the calcium is being bleached from the bone, it has to be urinated out. And the process of urinating it out, you could cause kidney stone that way. So when somebody presents with kidney stone for the first time, you don't know anything about them. You're just meeting them for the first time, or you knew them, and all of a sudden they come in with symptoms of kidney stone. You could take them to the ER, you do the kidney stone protocol, CAT scan, there it is, and or you find blood in the urine, and then of course you suspect kidney stone and so on. Well, you can't just say, well, I'm packaging you, here's a copy of your CAT scan, you go to your urologist. You can't do that. They might go there, but you also, in addition to that, either you send them to an endocrinologist or you send them to a general internist who is familiar with this kind of stuff so that they can be fully evaluated. Because the reason why they have the kidney stone does not necessarily mean it's just good old-fashioned kidney stone, which is a very painful disease. The patient may have certain malignancies, such as lymphoma, such as multiple myeloma, and they may present first with osteoporosis and or sometimes kidney stone. And the mechanism through which they have the kidney stone is because just because they get the disease, lymphoma, they didn't know they have it, and they have not started chemo or radiation yet, doesn't mean the cells are not breaking down. The cells are multiplying. As part of the normal maturation process, the cells have to die. When they are dying, they're releasing part of the contents of urates, and the urate's going to form kidney stone. So you got to be super, super careful. Somebody present with bone pain, and then suddenly you send for some sort of a bone density, they see osteoporosis, and you start treating them for osteoporosis. Guess what? The patient may have multiple myeloma. That's causing the bone pain. That's also causing the osteoporosis. And then you waited for months without realizing that something is going on. The patient is not getting better. Turns out that the reason is because they have multiple myeloma. I mean, this is serious stuff. And then you really have to open your mind all the time to be very thorough so that you don't miss diagnoses. And or you find how suddenly the patient have low magnesium. Once you know that the parathyroid gland that sits in the neck is under direct control of serum magnesium. How about that? That's right. That's exactly correct. So therefore, then, if somebody's serum magnesium is low, the parathyroid gland is going to shoot up, the PTH goes up, and then all of a sudden you're having, depending on how long this has been going on, it could be dietary in nature, it could be some other condition that's causing you to lose magnesium in the urine, and before you know it, you got a patient with osteoporosis secondary to hyperparathyroidism, only to find out it's not the adenoma in the parathyroid gland that's causing the elevated PTH, parathyroid hormone, is because the serum magnesium is low. I mean, this stuff is so fascinating, but it's extremely complicated, and I don't want to sit here and give you all the little details. But I want you to know, I know this stuff better than I know the palm of my hand. So therefore, though I don't tell you everything, that doesn't mean I don't know everything about this stuff. So let us then go about evaluating the patient. Okay, good. You take the history from the patient, you do a complete physical examination, and then you're going to send the patient for a complete blood count. That is crucial. You send the patient a complete chemistry profile. That is very important. You make sure you do a parathyroid hormone. You make sure you do a vitamin D, and I'll tell you what level. I'll tell you why in a minute. And then you proceed also to do a serum magnesium. You do a urine analysis. You do thyroid hormone evaluation. You do your PTH. And then almost always, remember, this is bone pain, always do a citrate. Always do a rheumatoid factor. Always. Because the patient with rheumatoid arthritis can also develop osteoporosis. So So you get all that stuff out of the way. Then you do plain X-rays, and or you may do a CAT scan if you suspect a fracture or something more serious, so on and so forth. And then you wait for the result to start coming in. Always also do a phosphorus. Do a serum phosphorus, serum magnesium, PTH, vitamin D. The reason why it is important to do vitamin D, because if your vitamin D is low, that can also cause the PTH to be high, the parathyroid hormone. So you can't talk about primary hyperparathyroidism if somebody has low vitamin D. So you must, after all said and done, and I'll get to it in a minute, once you find out the vitamin D is low, you must take it easy. Stop right here. You have to find out why is the vitamin D low. Okay, well, then you got to treat that. And the reason for low vitamin D could be dietary. It could be because the person has dark skin, and therefore the sun ray is not stimulating the beginning of the process, that is the production of vitamin D, which starts under the skin. And or the patient may have kidney disease. And then how are you going to know the patient have kidney disease? Well, you did a chemistry profile. When you look at the chemistry profile, what are you looking at? Well, you're looking at the sugar, because if you have diabetes, that can cause kidney disease. Then you take a look at the electrolytes. Electrolytes are absolutely, completely crucial. Very crucial. I may not take the time to detail to you why, but it's very crucial. Then you look at the blood urea nitrogen. You look at the serum creatinine. And then absolutely crucial, you take a look at the calcium. How about that? I have to stop there for a moment to see the meaning of the calcium. Okay. In primary hyperparathyroidism, it is expected that the serum calcium will be high. Remember, underline the word expected, because you could be fooled. Because you could have a perfectly normal serum calcium and still have primary hyperparathyroidism. How about that? Because there's a condition called normal calcemic primary hyperparathyroidism. So just because the book says that the serum calcium has to be high doesn't necessarily mean it has to be. And yet the patients still have primary hyperparathyroidism. Okay? And once you realize that the patient has primary hyperparathyroidism, then you must do a sestamibi of the neck to evaluate the parathyroid gland, display them anatomically so you could see them to see what's going on, okay? And then, of course, if it is an adenoma and the patient is very sick, then you may find your neck surgeon getting involved to remove one or two of the glands, because there are 4 of them. Can't remove all of them. I mean, I can go on and tell you how you go about all this. So, and then you take a look at the blood chemistry. I mean, at the blood count. We talk about the chemistry. About the blood count. Well, what are you looking for at the blood count? Well, you're looking for anemia. You're looking for, is the platelet okay? Is the WBC okay? Because if you have a patient who has some sort of lymphoma that is occult, that hasn't shown its face yet, and the differential count and the CBC might be your first clue that your patient have CLL, chronic lymphocytic leukemia, because it will display for you the white count will be elevated, and the abnormal blood cell, the lymphocyte will show in the differential, and so on and so forth. So the blood count is crucial. Anemia, well, if you have kidney disease, there are thousands of things that can cause anemia, but kidney disease happen to be one of them. You say, well, how come? Well, there's a hormone that is made by the kidney, specifically made by the kidney, by the human kidney, without which you cannot produce red blood cell. Simple as that. So therefore, it is very important to know whether the kidney is sick or not, because if the kidney is sick, you have renal insufficiency. The sicker the kidney, the more abnormal or the more severe the anemia. So these are very important things to keep in mind. So that's what you're looking for. and the blood count. You're looking for the anemia, you're looking for the white blood cell, you're looking for the platelet, and you're looking for the differential count. Under the microscope, you're looking at it to see if you're going to see abnormal cell that might point to you that the patient may have a problem. Well, I mentioned doing the erythrocyte sedimentation rate. Well, crucial, because all inflammatory conditions and all infectious conditions will cause the SED rate to be elevated. Well, a long list of rheumatological problems are all inflammatory in nature, so the SED rate will be up. Right away, you raise your red flag. You must explain why is the SED rate elevated. And the process of explaining that, you may wind up making a very crucial diagnosis. You can't have multiple myeloma, which is associated with osteoporosis, without having an elevated SED rate. See, so you have to understand the SED rate is not specific, but it points certain things for you. In the process of doing your chemistry profile, you do an LDH, lactic dehydrogenase. How do you go from LDH, which is produced by the liver, and talking about a malignancy process? Well, let me tell you why. Cancer cells, my friends, grow via the anaerobic pathway. Let me repeat that. Cancer cells grow via the anaerobic pathway, meaning that they grow in the absence of oxygen. They grow in the absence of oxygen. And the end product of the anaerobic pathway happens to be lactic dehydrogenase. I mentioned over the years that I've been doing this show that there are keys or other gadgets to open any lock. Well, to practice clinical medicine, you can't do it by doing protocol, because 72% of what physicians, clinicians do is based on judgment and experience. Well, you have to walk around and no head all the time with hundreds of keys to major medical problems. If you don't have them, that diagnosis is not there. Well, you're not going to have a malignant process, in particular hematological malignancies, with a normal LDH. Simple as that, because I just finished telling you. The end product of the anaerobic pathway is lactic dehydrogenase. So you check an LDH when you're doing the chemistry. If your LDH is high, you're forced to explain it. You have to understand there are other conditions that can cause elevated LDH, such as hemolysis. I'm not talking about that. Yes, there are many malignancies. Yes, there are many rheumatological diseases that are associated with hemolysis. But my friend, there are other ways to make sure that elevated LDH also is not due to hemolysis, because you can't be hemolyzing with having a normal reticulocyte count. So if that's your concern, you're dealing with an autoimmune problem that may be associated with a rheumatological problem and osteoporosis, you check reticulocyte count on your request form. Because if you are hemolyzing, both the LDH and the reticulocyte count will be high. How about that? But if you check that, the reticulocyte count comes back normal, the LDH is high, so you just rule out hemolysis to explain the elevated LDH. So, I mean, those things are absolutely crucial to eliminate different things so you don't spend thousands and thousands of dollars and lots of time chasing diagnoses that don't exist, because you know the keys to the lock or the gadget you have to press to put a code in to open the doors. You have to know these things. Otherwise, you see, to diagnose medical problems, you think that you're going to stumble on things by chance? Give me a break. Keep waiting In the meantime, the diagnosis is not established because you hopefully by chance will stumble. It doesn't work like that. Experienced physicians, and there are hundreds of thousands around there, out there, know these things. So now then, you do your blood count, you do your chemistry, you do your sedate, you do your rheumatoid factor, you do your LDH, you do your reticulocyte count, you do your vitamin D level. Your vitamin D level comes back normal. Then right away you know you can't blame it for the osteoporosis because the vitamin D is normal, okay? Then you got to search for other reasons to explain why the patient have osteoporosis, okay? So now then you do the x-ray. I have here on the screen a patient, a chest x-ray of someone who has osteoporosis. Look at all these vertebrae have collapsed. That's why the people get shorter as they get older because the bones become softer and these things are collapsing on each other. And this is, take a look at this. This is how terrible that looks. These are the vertebrae in the chest. Look at, they're all terrible. They're soft. They're getting ready to collapse to it one on top of another. That's what osteoporosis will do to you. And I'm just showing you the chest. All bones in the human body, from the toe to the pinky finger, can be affected with osteoporosis, causing deformities, pain, and etc. And I'm not a radiologist, I'm not an orthopedic doctor, but I want you to know these specialists are fantastic. They know this stuff better than I do. I wanted to also run by you, sticking a little bit with vitamin D, because you have to understand how important vitamin D is, because you have so many, 90% of dark-skinned folks have low vitamin D. Take a look at the world, 7 billion people, okay? 4 billion of the 7 billion lives in Asia. And there are many, many, many places in Asia where people have dark skin. 1.5 billion lives in Africa. So that's 5.5 billion right there, okay, which left you only 1.5 billion for the rest of the world. I did not get to Europe yet. I didn't get back to the Americas yet, and so on and so forth. You could figure out what I'm trying to say. So this is how common vitamin D is, okay? Deficiency is. 90% of Negroes, 55% Caucasian, 55% Asian have have lactose intolerance, which can also cause low vitamin D. I have here a list. By the way, this chapter that I'm talking, that's in my hand, is chapter 77, and it comes from this book, The Art and Practice of Modern Clinical Medicine, which I wrote in 2016. Let me go with you, review the foods that are very good source of vitamin D. Milk, cheese, yogurts, beans, eggs, kale, cauliflowers, chard, molasses, rhubarb, beets, almonds, cabbage, carrots, celery, dates, chocolate, figs, lettuce, lemons, oranges, oyster, pineapple, raspberry, shellfish, spinach, walnuts, watercress, parsnip, etc. So the list is quite long of things that have vitamin D, but people can't eat cheese if they have lactose intolerance. They can't drink milk if they have lactose intolerance. I know I can't. I mean, I survived on milk stuff because it was very cheap when I was growing up in Haiti, which is a very poor country. I know I was very poor, and it was the cheapest thing to get. But as you get older, the lactase, which is found in the wall of the colon, begin to dry it out. The older you get, the less you have. Now I can't touch that stuff. If I touch it, I'm sick for 2-3 days, okay? But why? Because I obviously don't have any more lactase left, because you need the lactase to digest the lactose. And all these dairy products are rich in lactose. And there's so many people across the world. I just give it to you. 90%, 75% black folks, 55% Caucasian, 55% Asian, etc. All these folks have lactose intolerance to one degree or another. So this stuff is crucial because you have to understand that I just finished telling you that the parathyroid gland is under the direct control of magnesium. And magnesium can be lost very easily in the urine through the kidney because of a lot of medical conditions. So you have to check. You have to check the serum magnesium, check the urine magnesium, check the phosphorus, and check the calcium. Your calcium can be perfectly normal, and you still have primary hyperparathyroidism. So it's very important to remember that. Don't get hung up looking at the calcium to think it's going to be high. And you cannot begin to talk about primary or secondary hyperparathyroidism unless you resolve the issue of vitamin D. You must resolve that issue. And the sicker the kidney, the higher the possibility of having low vitamin D, because I-125 is come from the kidney back into the bloodstream. It goes to the liver first and then goes to the kidney. It's only has to reach the kidney for it to be processed, for it to be meaningful to the human body. I'm serious. No matter where you take the vitamin D, either through the skin or you're eating it, it must first go to the bloodstream and into the liver. From the liver, it gets processed, gets sent to the kidney, and it is the part that's coming from the kidney is the part that is useful to keep you in vitamin D good level. How about that? So therefore, if the kidney is sick, can't process it to I-125, therefore you get yourself state of low vitamin D. Listen, I'm going to stop here. I'll continue the discussion about osteoporosis next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.